Hi, good morning everyone. So today I'll talk about how to overcome the fear of cataract and glaucoma after ICL surgery. So there are two main reasons for cataract formation after ICL
A little
surgery.
louder, please. You can have the mic closer to you.
Yes.
Yeah.
So there are two main reasons for cataract formation after ICL surgery. First is ICL and crystalline lens touch, and the other is excessive irrigation or irrigating fluid jet hitting the anterior capsule. So first I'll discuss about the one which most of us are aware of and afraid of, that is ICL and crystalline lens touch. So I'll discuss about both the scenarios. So now first let us, so this is a case of minus 30 diopters patient which we operated upon 15 years ago. We did his ICL surgery and we did it with the we did with the ICL without holes, that is V4 model. So this is how his vault was. It was very shallow in the periphery, and in the center we had an ICL crystalline lens touch. So 15 years ago, we didn't have much experience whether we should just continue with this ICL, exchange it with the higher vault, or just observe. So at that time, we decided to just observe and follow up the patient. We asked the patient to come for a yearly follow up. So it went on very well for a couple of years until in the fifth year of follow up, we noted this speck on the anterior capsule of the lens. This speck on the anterior capsule was very peripheral. So it was basically anterior subcapsular cataract developing in the periphery. It was very peripheral and small, and it was not affecting the vision. So we decided to observe it. And the patient again followed up with us on yearly basis. It went on very well for another 5 years. Until in the 10th year, the patient developed the central cataract in both the eyes, and we did his both eye ICL surgery. So in this case, what I want to focus on is that the patient has a ICL crystalline lens touch right from the very beginning. And the model was old V4 model without the holes, and it worked very, very well for 10 years until we had to do the cataract surgery. So here is another case, similar case with old V4 model where we did the uh, ICL implantation and we got another anterior subcapsular cataract. This cataract also developed in the fifth year of follow-up. So this is the anterior subcapsular cataract as seen in the retroillumination, diffuse illumination, and slit lamp illumination. And we did his cataract surgery after 5 years. So all these cataracts developed with the old V4 models. And we have started using newer V4C model, that is ICL with hole, since 2014. And we have not encountered a single case of cataract since then. Even if we have vaults as low as 84 microns or 100 microns, we are seeing the patients on follow-up, they don't have any anterior subcapsular opacities. So this is how we counsel a case of patient who asks us about the risk of developing cataract after ICL surgery. We tell the patient that the cataract happened in early V4 models, that is ICL without hole. It does not happen with the newer V4C model, that is ICL with hole. And that there are several studies which mentions incidence of cataract as 0 in last 5 years. The incidence of cataract is actually as low as 0.1%, which is safer than going out on the road. So we tell these patients that since the advantage of ICL is huge and the risk of cataract is so small, this risk is worth taking. And we tell them, even if in rare situations cataract does happen, it can be managed very well with the cataract surgery without any visual loss. So another cause of cataract formation, which most of us are not aware of, is excessive irrigation or fluid jet hitting the anterior capsule. So this is the picture of the patient on the first post-operative day after ICL implantation. We saw the whitish deposits on the anterior surface of the lens. These are the whitish deposits as seen on the slit lamp illumination, diffuse illumination, and retro illumination. At first, we thought that these were the retained viscoelastic material which has caused these white deposits. These deposits decreased over a period of time, and at 3 months follow-up, they had almost disappeared and there was no vision loss. We saw 3 to 4 such cases. And we thought if retained viscoelastic is the problem, why don't we stop using the visco and start implanting ICLs under hydroinsertions? So we stopped using the visco and started doing hydroinsertion of the ICL. So after we started the hydroinsertions of the ICL, 3 months later, we saw a similar such case where we saw the white deposits on the anterior surface of the lens. So on follow-up, like the previous cases, these deposits decreased by day 30th without any vision loss. It really got us thinking what it was, because the amount of viscoelastic we were just using viscoelastic in the injector to load the ICL, the amount of which was very minuscule, and that too we were washing with the hydro. So how can such a small amount of viscoelastic be deposited on the lens? We kept on wondering, but we didn't find any answers. So 1 year later, we saw another case with huge amount of deposits on the anterior surface of the lens. So we checked up the literature and we found a case report which mentioned about the vacuolar changes on the anterior subcapsular space of the lens after irrigating procedures during the phakic IOL implantation. So it mentioned that the vacuolar changes developed just after the irrigating procedure through the narrow space between the ICL and the crystalline lens. It also mentioned that these whitish deposits appeared like bleb-like lesions as seen on the ASOCT, and that these lesions gradually improved without visual deterioration. So we also went ahead and did the ASOCT of our patients, and we saw similar bleb-like lesions. So from all these cases, we learned that retained viscoelastic was not inducing, it has no role in inducing cataract, or these were not inducing subcapsular vacuolar changes in cataract. It was excessive irrigation that was causing transient anterior subcapsular vacuolar changes on day 1, which would improve with time without any visual loss. But the main thing to learn here was that during hydro insertion or visco removal, even if you're doing it under visco, during visco removal, never irrigate between the narrow space between the ICL and the crystalline lens, because when you irrigate between them, you hit it with a lot of pressure, and these causes vacuolar changes. You should also keep the irrigation flow and irrigation time to minimal, and your IOP setting should be low and the bottle height should be low so that there is this less strong irrigation jet. So another fear is that of glaucoma after ICL surgery. So the 3 main causes of glaucoma after ICL implantation surgery are retained viscoelastic, high vault of ICL, and the ICL placed upside down. In the immediate post-operative period, one can get high IOP because of the retained viscoelastic. The retained visco can clog the drainage channels, which requires IOP lowering agents until the viscoelastic is washed off. Now coming to a very important thing is high vault. The vault is generally called as high if it is more than 1000 microns. So if we get a high vault, what we do, we are always in a dilemma whether now we should exchange the ICL, just observe it, or remove it. What we do here is we do the IOP monitoring of the patient and we check the angles on gonioscopy and ASOCT. If the IOP is normal and the angles are open, we wait and watch. And if the IOP is raised and the angles are closed, we replace it with a one size smaller. So I'll show you the case scenarios. Here we had a patient of vault up to 1400 microns, but his IOP was normal, and as seen on the ASOCT, the angles were open. So we decided to follow up the patient, just observe the patient, and after 1 year of follow-up, the IOP is normal and the patient is doing absolutely fine. And also, if you get a very high vault, there should be no hurry in exchanging the ICL if the IOP is normal. Here is one such case where we observed that how the vault decreases over a period of time. When we saw the patient on the first post-operative day, the vault was very high. It was 1583 to start with. After 1 month of follow-up, it decreased by 100 microns. By 8 months, it decreased by 165 microns, and by 14 months, it decreased by almost 350 microns. So there should be no hurry in exchanging the ICL as the vault decreases with time. So now coming to another scenario where we did have to exchange the ICL. This is a case, this was an extreme case, like we had a very, very high vault where the ICL was vault was so high that the iris was touching the endothelium of the cornea. And when we did the ASOCT, we saw the angles were absolutely closed. So we went ahead and immediately removed the ICL. The surgery was very challenging, and the AC was so shallow that there was ectropion uvea as the ICL was pushing the uvea from below. There was no space for manipulation. We didn't have even space for the side ports to enter. So we opened up the same side ports. So there was hardly any space for manipulation of the ICL. Normally, when we have to exchange the ICL, we bring out one of the edges of the ICL into the anterior chamber and then pull out one edge. But since here, in this case, there was no space for the ICL edge to come out, we just managed to grab one edge of the ICL and just pull it out of the eye. We then implanted the ICL with the one size smaller, and this is how the vault was after the surgery. So last but not the least, I'll show you a case of ICL placed upside down causing glaucoma. This was a case done elsewhere, and we saw this patient 5 years ago. When the patient first came to us, we saw that there were peripheral anterior synechiae and the AC was very shallow. So when we dilated the patient, we saw that the ICL was placed upside down and the CD ratio was 0.7. So the patient had glaucoma. We put the patient on the IOP lowering agents and we did the surgery. We tried to break the peripheral anterior synechiae, but we were not successful in doing that. So we brought out one edge of the ICL into the anterior chamber, pulled the ICL out, we turned around the ICL, brought it into the right configuration and re-implanted the same ICL in the eye. And the patient is doing absolutely fine now. Thank you. Sorry? This is the ICL holding forceps. Now there is one, when we do the IOL cutting, there is one separate forceps for holding the IOL. These are the IOL holding forceps when we have to cut the ICL, IOL.
This is is with epsilon, and it comes as an IOL holding and
cutting forceps.
So there you need a very strong grip on the IOL if you have to cut it with scissors.
This is round in the front and very blunt. So once I tried using some other forceps and I broke one of the edges of the ICL. So these forceps are very, very safe. They are very blunt and...
Which is the brand of this forceps?
Epsilon.
Epsilon. It's Dr. Chaudhary's forceps. Okay. So, the normal ICL holding forceps are those alligator forceps. The problem with those alligator forceps is it's very long. And when you try to hold it, sometimes you tend to push with either the lower one or the upper one. And the lens moves a bit, and then when you grip it, it is not exactly aligned and it opens up a little bit sideways. So we changed the forceps design to make it a little smaller with a very good grip like what you saw now, so that we just go and hold and bring it out. The forceps do not push the ICL in the cartridge. So the alignment always stays perfectly in one line. So this forceps is working very well for us. Any questions, Doctor? This is a very important topic, Dr. Dhami here. Dr. Sarika, would you like to come here? You can answer from here only as a panel discussion. Yeah, Dr. Dhami, sorry.
That's a beautiful ASOCT of the day capsule and a very good concept that you carefully irrigate after putting the ice. But this accelerates what you call as little material under the lens usually comes after one particular ICL, that is IPCL. Not all.
No, I didn't get you. Just come again.
You mentioned about the irrigating fluid.
Yeah.
The subcapsule spaces.
Sublenticular space. Huh.
Very nicely elaborated and said. But the second thing, that there is a whitish material collected over the surface of the capsule, the lens capsule, is very particular with IPCL on the first, second week. No other ICL.
We have not
I have really not experienced that.
How it can be related with that particular lens?
Because it comes only with the surface. That's why we start putting that.
See, in between with this lens, there was a problem. We know about it.
Being given from around it.
Yeah, but as such, we have never seen something like that happen. Maybe our volumes of IPCL are not too high. We are just using it very high powers.
That's how we start.
We only use it in very high powers, and that too, our biotech lenses are more in use than the IPCL, because the biotech lenses had a cylinder accuracy in these high powers, which was initially it was a little erratic, and then when we started giving them the feedbacks, they started correcting their powers in their nomogram, and now the nomograms that they are using gives us a fair good correction. Suppose you have a number of -25 with -3 cylinder, or -22 with 6 cylinders, the biotech's accuracy is pretty good, plus minus half. The other company, the accuracy is still wanting, because these ranges are very rarely used, and their normal ranges, they work well in all the lenses, but these extreme ranges, they still have to customize their powers, and we find a lot of difference with the other company. So that is why we have done it with hit and trial with one company. Now we don't have the heart to again do a hit and trial with another company. So we are using biotech lenses more in very high powers. Though technically I would prefer the thinner lenses, the Care lenses in high power, because in any case your lens thickness is becoming higher in higher powers. So if the lens is thinner, it makes more sense in the same ACD. No? So that is why I would prefer the Care lenses given the choice.
One more question about the rotation of the limb. A patient comes to you, he has been implanted about a month back, a spherical IC, and he comes with a good cylinder power now to you.
A spherical lens comes with a cylinder power.
Could it be rotation of the lens? Could it be inflammatory cause? What can be? Because the only thing we could note was the decrease in the lens and the ICL and the lens here. Means what?
Could it be a subluxation of the lens or a damage to the zonules, which is making the lens, the crystalline lens, tilt? See, if the crystalline lens tilts, it will cause a cylinder. A spherical lens, if it moves around, it cannot induce a cylinder unless it tilts. And any lens which tilts will cause a cylinder. So either the crystalline lens is tilting or the phakic lens is tilting.
So what was the magnitude of the cylinder?
Approximately 3.
3.
No, this.
This is anecdotal, one case.
First one case, he is a doctor who has been operated elsewhere, and very difficult to explain to him because he understands everything. Should he be advised to get lens explanted or rotated in another?
Who would bill the cat?
The man who has put in.
So you send it back to him, na? With advice.
I think we need to do some workup on that, so like calculating where from where this is.
A good ASOCT, like the Interion, which gives,
It shows no wall.
no, which shows the lens, the crystalline lens alignment. It will also show the ICL alignment. Because the normal ASOCTs, which are basically retina OCTs, will give you only a thin strip of the ASOCT area. It's only the Interion, which is the dedicated one, which gives you right from the epithelium to the posterior surface of the lens. You have the whole OCT area. So that gives you the exact alignment of the lens in the eye. Crystalline lens and the ICL lens. And that will probably tell you exactly which lens is tilting. Yeah. High cause of a high vault. See, high vault basically is only one cause, and that is you have done a calculation on a white to white, and you are assuming that the sulcus to sulcus is 1 millimeter more than white to white. What if the sulcus to sulcus is not 1 millimeter more? It is just half a millimeter more or the same. It's a blind area. So your lens would be tight. And once, if this is the ICL, if it is tight, it will vault. If it is loose, it will flatten out. So there's something which is making it tight at the periphery. Either it is not gone into the sulcus, it is somewhere hitting the iris root or something. That is why it is vaulting. But usually that doesn't happen. It slips into the sulcus. So it's the size only that causes a higher vault. Less than 2.8. Yeah, but I would not recommend 2.7 for people who have not done a good series of lenses and have become experts. Because if something goes wrong, how would you refer or take an opinion of another senior ophthalmologist? No. Why experiment with something which is outside the accepted ranges, where you will have to control the situation? You can't seek an opinion of another person.
I have put the spherical, but avoid the tall ICL because the number is the standard power is 0.5.
Yeah. Cylinder 0.5, you can do a spherical ICL, na?
It's working very well 6 months ago. But I am asking if can we go for toric ICL?
Yeah, why not? If your confidence is good, yes, because even half a cylinder can be a little disturbing. But if you give incision on the steep axis with a 3.2, it does correct 0.1. But that 0.1 or 0.15 cylinder is so minimal that it's really not making too much of a difference. The difference is when you make a small incision and you are forcing something through that small incision so that the edges are kind of tearing and becoming rough at the cut. But if your incision is bigger and you are not kind of disturbing the anatomy or you're not making it the incision bad at the angles, then the cylindrical change is negligible. So even a side port, which with a irrigation aspiration system, which is making it very tight and causing fish mouthing, will induce more cylinder for a 1 millimeter incision than a 2.2 or a 2.8 millimeter incision where there is no fish mouthing.
How you will the financial aspect in case of lens exchange, second day or third day?
Financial means we don't charge anything to the patient, and the companies replace it. You just have to give that lens back to them. They assume that once in a while you will land up in a problem because you're putting it in a blind area, and they have provision for that.
But still the company asks for around 10,000 rupees for an exchange also.
It depends on your volumes there. If your volumes are low, they would charge. If your volumes are high, they would give it up.
I just got your hydrochloride that you just told. I just want to reinforce what you said. I've been doing hydrochloride for the last many years. It works beautiful. No reaction, very quiet AC, and no IOC hiccups. And one observation and one question also. Once, about 700 years ago, or even more than that perhaps, we put a lens of a different company in both eyes. In one eye, the people didn't come back to normal. It was different.
Yeah. So that is that syndrome. Now, what is that syndrome called? Jurits-Zavalia syndrome. And that does not come back. It is because of ischemic changes and it's not rare. We have had almost about 7-8 such cases of Jurits. We said it will become okay with time. Just give it time. It is a question of, in refractive surgery, the basic rule is who tires out first, the doctor or the patient. If the doctor says, sorry, we are done, now best now, nothing can be done, you have to live with it, you have had it. You say, okay, fine, I'm giving you these drops, put it for another 6 months and come back to me. You cannot say that the patient will give up, no? He'll get used to it, he has other things in life to worry about than a Jurits. So refractive surgery, your first principle is you don't admit that something has happened which you can't take care of. The patient, let patient tire out. कितनी बारी आएगा? बोर हो जाएगा. हाँ तो उसको दे दो ना कि okay अभी एक नई दवाई आई, I'm going to put you this medicine. This is known to have very good results. Put it for another 3 months. Show me.
Because of ischemia, you're pressing on the
It's a ischemia. Yeah. Yeah.
pressure of your
Yeah. It's ischemic.
putting restrictively people after putting FDIC better than not putting fluoroscopy.
Come again.
We usually constrict the people after putting the ICL.
Yeah.
Can that prevent this behavior?
No. It just happens. Yeah. It just happens. Sorry.
Yeah.
I put it as a routine. Why? Because remember, once you put the ICL in the eye, the AC has become shallow. Right? Very shallow. And the moment there's a little egress or coming out of the fluid from especially the main port, the iris comes with it. So when you are hydrating the edges of the incision, there's a chance that the iris starts prolapsing, and then you have the consequent problems.
I think that can be taken care of on the table. I usually don't do, except rarely when the people is not getting restricted in time.
It's a very personal choice. It's a very personal choice. I think almost 60-70% of the people don't use carbachol or pilocarpine. for me, it's become a routine. You know, it works at the spinal level. हल्का सा एक आधी बूंद डाल दी और फटफट हाइड्रेट किया और बंद कर दिया. And I don't get that iris in the incision, and I'm very comfortable. It's a very personal choice. It's not a must. There's no scientific rationale of saying that you have to constrict the pupil.
Sir, as a general ophthalmologist, what basic thing we should have to do this ICL?
What basic?
Basic investigation. What?
And
4. Your first 3 are mandatory for calculation. Which is the refraction, the white to white and ACD. And the 4th is retina. Now, that is a big issue. We have retina people with us. They can see the peripheral retina and see whether there are any lattices or holes, and they do it.
Is endothelial not mandatory?
Huh?
Endothelial not?
It's not that mandatory. It's not, if you have it, better, but it's not mandatory. It's only retina is important because you have people with high myopia, and these high myopes are prone to retina detachment. Though we say ICL does not induce retina detachment as such because you are not changing the volume in the eye. In RLE, you're changing the volume in the eye. So the big lens is becoming a thinner lens. So there is more space and there is more movement, and the retina can move and detach more easily. So that's why the high risk in RLE. But in ICL, you're not doing something. Instead, you're adding volume, not reducing volume. So the risk of RD is very less. But an RD which happens after you're done an ICL, it may even happen after 10 years. They will blame you. कि जी पहले तो हमारा बच्चा अच्छा बोला था, जो भी हुआ ICL डालने के बाद ही हुआ. नहीं. They will blame. If they get an RD before putting an ICL, तो किस ऊपर वाले की मर्जी. लेकिन अगर डॉक्टर ने ICL डाल दिया और फिर RD हो गया, 20 साल बाद भी हो गया जी, पहले तो बच्चा बिल्कुल ठीक था, ये तो ICL डालने के बाद ही हुआ है. So your good retina checkup, and in the follow-up, we say 1 yearly for the ICL. It is not for the ICL. ICL में क्या होना? It is for the retina that the follow-up is more important.